Welcome, and thank you for joining us today. My name is Steve Eck with Modern Healthcare, and I'll be moderating today's webinar, Maximizing Eligibility and Enrollment Through Virtual Technology. During this webinar, we're going to have a discussion with industry experts about how healthcare providers can identify solutions that best meet the clinical needs of patients while ensuring reimbursement for services provided to protect the financial health of their organizations. A couple quick housekeeping notes before we get started. We want this webinar to be an interactive experience for you, our audience. Throughout the webinar, you are encouraged to ask questions using the questions pane in your GoToWebinar attendee panel. Our speakers will address as many of your questions as they have time for. We also have a few live polls throughout the presentation you won't want to miss. Should you need any assistance during the webinar, please don't hesitate to contact us via the questions pane in your attendee panel. We'd also like to thank our sponsor, Civista. Civista provides operational transformation services and insights to acute and ambulatory facilities and systems. They enable their clients to navigate the biggest challenges in healthcare, quality clinical care with positive patient experiences and optimal financial results. You can learn more at civistarcm.com. We have a lot of great content for you today, so let's get started. It's my pleasure to introduce our speakers for today's webinar, Amy Newsom, Senior Director of Revenue Cycle at Civista, and Lakshmi Patel, Chief Strategy Officer at Civista. The floor is yours.
Thank you, Steve. As Steve mentioned, I'm Lakshmi Patel. I lead strategy for Civista. I, along with my colleague Amy Newsom, are excited to present Maximizing Eligibility and Enrollment Throughout Virtual Technology. COVID-19 created many challenges for us and some new challenges that the healthcare industry hasn't faced, particularly with patient engagement and interaction, but also new opportunities for advancement that we probably wouldn't have had if we weren't forced. So by maximizing on the benefits of virtualization for patients, hospitals can ensure appropriate reimbursement for services to protect the financial health of their organization. I want to introduce you to Amy Newsom, Senior Director of Revenue Cycle for Civista. Amy has experience managing patient eligibility services for over 2 decades. She has an in-depth knowledge of eligibility requirements at both state and federal levels, and extensive experience in providing access to care to healthcare providers' most valuable and vulnerable community members. Amy has the insights needed to understand and navigate the complexities of eligibility service as its delivery changed in the healthcare industry. So I'm turning it over to Amy.
Thanks, Lakshmi. Really excited to talk with everyone today. So we're going to go ahead and get started. And I actually want to kind of talk about trends in the patient access market to start. So we can go ahead and go to the next slide. All right, so when we think about eligibility and enrollment services, typically that's a front-end service, so it's usually rolled up under patient access. And we want to talk about the overall trends in patient access. So we're seeing this complex regulatory landscape, right? Healthcare providers are facing reimbursement pressures that are driven by a shift from that traditional fee-for-service to value-based models. At-risk revenue and the complexities associated with new reimbursement models are challenging operating systems, and they've always had thin margin profiles. Administrative costs, they're expected to increase 100 to 300% in the next 5 years. And when we think about patient responsibility, we're seeing this continued rise in the patient is the payer, right? The patient responsibility is the 3rd largest payer in revenue cycle, and patient medical liability for self-pay patients, those without insurance who pay for services out of pocket, that's growing 20% each year. So with the increased patient responsibility and the cost hitting the patient's pocket, there's more patients that are performing research on cost of services. They're looking at, provider peer, they're looking at the provider's reviews, and there's this expectation on how the service is delivered. And then you have the rise in cost utilization. So in the market, we have a lot of needing to do more with less. And we want to really look at how do you increase the ability to collect and be able to create the experience, but oftentimes less resources and spending overall. So we're going to go ahead and go into the next slide, which is actually a polling question. So we're going to kick off the poll, and the poll is, do you use telehealth in your functional area? So if you could take some time to enter your answers there.
And I want to add to the context when you're answering this from a telehealth perspective. I think we think of telehealth as more of the actual delivery, the clinical service piece of it, but also want to think about telehealth or televisit in a functional model also. So are you utilizing it from a virtualization standpoint too? Right, it looks 65% saying yes. So very on trend with what's happening in the marketplace. You know, telehealth, when we look at the traditional model, promised a lot of benefits with ease and convenience from a patient care standpoint. But prior to COVID-19, it wasn't readily scalable across the healthcare system or really adopted. And it had a lot to do with the restrictive state and federal regulations around it, the inconsistency from practice by commercial payers, with really limited telehealth reimbursement. So an in-office visit for the same service, you are getting paid 20, 30 times more than a virtual visit with the same results. The mainstream adoption of telehealth also was compounded by the challenges of the integration of virtual care technologies with electronic medical record, and how do we really continue to making sure that the visits are actually coming up from the right determinants of health and are having the right impact. So as the regulations kind of change, is allowed us to open up opportunities, which has also allowed us to translate some of this cohesive patient experience from the actual clinical care to the patient experience after the fact.
Yeah, and I wanted to, kind of talk about that, Lakshmi, with this survey here. So essentially, there was a survey that was done related to Medicare beneficiaries and as it related to telehealth. And 1 in 4 Medicare beneficiaries had a telehealth visit between the summer and the fall of 2020. And it was identified that 27% of providers that offered telehealth, the beneficiary had that visit. 33% of the providers that offered telehealth, the beneficiary did not have the visit, and 40% was either that the provider didn't offer telehealth or the offering was unknown. So we are starting to see, especially with those survey numbers, that more providers are shifting to telehealth offerings and moving forward.
Yeah, and just to add to that, Amy, providers nationwide switched to 1/3 or more of their in-person care to telehealth and video encounters on the onset of the pandemic. While the volumes of those visits have declined over the recent months, but it's still at an estimated of 15%, which is far beyond the pre-pandemic baseline of less than 1%.
Yeah, and if we look at the next slide, just as it relates to, telehealth, and you made some really good points there about, the adoption of telehealth and how it really wasn't widely used prior to the pandemic. Well, here it's showing that, greater than 80% of respondents indicated that telehealth actually improved the timeliness of care for their patients. So now we talked a little bit about telehealth, but I kind of want to go into talking about patient liability and consumerism. And so if we go ahead and go to the next slide, there was a poll that was conducted specifically with hospital systems where the question was, what is your greatest revenue cycle need? And the top two that I'm going to talk through a little bit today, is the value-based care reimbursement and alternative payment models, as well as patient liability and consumerism. In addition to that poll, it was identified through the survey that 79% of patients consider billing and payment experience when they're choosing a healthcare provider, and 51% of patients are concerned about affording their bill and having insurance coverage. So when we talk through, value-based care and alternative payment models, on that next slide there, the value-based care, it's a healthcare delivery model in which providers, including hospitals and physicians, are paid based on the patient health outcomes. And it differs from that fee-for-service model in which providers are paid based on the amount of healthcare services they deliver. These type of models, they do allow for providers to focus on the patient's care and not have to worry about cash flow. And ultimately, they're doing the right thing for the patient, which is the patient's care. This payment model, it's typically prospectively determined revenue stream. It's an evolution of risk sharing, and it produces value and high quality health. This type of model does focus more on patient outcomes and beneficiary experience than on the process, and it reduces program expenditures and improves quality of care. Providers can be enrolled into these value-based care models with like your managed Medicaid, right? Or they could be partnered with a DCE entity provided with CMS. Part of receiving the benefits are incentives in this model, and incentives in this model with payers, so it supports social determinants of health, right? So that's supporting patients by ensuring that the patient has access to community benefits, which can aid and support their care, such as, you think of food stamps, transportation, pharmacy assistance, helping the patient with their medical benefit or secondary Medicaid coverage, right? So being able to help reduce and mitigate that out-of-pocket expense, as well as providing a benefit that's gonna help that patient from encountering a unplanned visit through the emergency room or having a hospital inpatient stay. And I kind of want to give like a little bit of an example of that, right? So if you have like a diabetic patient who needs to see a dietitian or a nutritionist to regulate their diet, and they have access to, they don't really have access to the healthier foods, right? So they may need that access. And so they also may need the access with a payer to help reduce some out-of-pocket expenses for seeing providers and specialists. So being able to help get that patient on food stamps so they can go and choose healthier foods, helping them get a medical benefit, is all helping them to reduce the number of times that patient actually can go in the hospital for diabetic-related reasons.
We do have a question on this slide. Can you please provide clarification on the difference between value-based model and a direct contract entity?
Yeah, definitely. I mean, essentially, value-based models and direct contracting entities are both value-based care. Essentially, it revolves around patient treatment and how well a coordinated care team can improve the patient outcome based on certain metrics, like reducing hospital readmissions, improving preventative care, and using particular kinds of certified health technology. In fact, CMS, there was actually 7 original value-based care programs that CMS had issued, even back, it started around 2012, right? The DCE model is actually the same thing, but it's an alternative payment model. It was launched by CMS that enables chosen providers to support the quality care initiatives. And they incentivize those providers to maintain and improve the quality outcomes for the traditional Medicare fee-for-service beneficiary while reducing their healthcare costs. So the DCE model, it's expanded to broader range of medical groups, physician groups, health systems, risk-bearing organizations. In fact, there's 51 DCE participating providers issued by CMS for the 2021 performance year, and they're serving in 39 states. All right, so if there's no other questions there, I'm going to go into and talk through that second starred item, right? We're going to talk about consumerism and the patient experience. And so essentially our patients are becoming consumers, right? And this is all really important when we start talking about eligibility enrollments here soon. The burden of healthcare costs, it's shifting from the payers to the patients. And with the trend, patients are doing research, right? We talked about that. They're looking at the cost of services. If the patient's responsible for that liability, they want to know, how much does the service cost? What is the type of service they're going to receive? So, you know, it has a lot of patient-enabled healthcare services, and patients are using their own technology. They're doing their own research, right? So there's also some competitive options in the market today. You know, we're seeing medical kits that patients can purchase. And you have CVS, you have Walgreens, and now offer clinics. So these are new options that are going to be disruptors in the market, and patients are taking ownership of their healthcare, and they're becoming very savvy in the way they look at healthcare. Lakshmi, I was going to ask you, you know, if you had like an example of like consumerism that you could share.
Yeah, you know, I mean, I actually think about from a healthcare perspective, I think we're behind when we think of consumerism and certain and thinking about our patients. Historically, we've thought about the patient experience or patient journey mainly focused around the clinical process and the clinical touch. So what is the experience with the doctor, the nurses, the technicians that are providing the actual care? But as you mentioned, like the access to information, because it's available in every other industry, and the coupled with the rise in healthcare costs, if I'm going to pay for something and I'm going to pay a significant dollar amount, I expect something differently. So I relate it back to, you know, 10 years ago when we had the options of HMO plans and low deductible PPO plan. Convenience was a priority. But now with high deductible plans where people are paying $5,000, $10,000 or more of deductibles before their even reimbursement starts, it's no more about convenience of care. It's about the experience throughout and the level of information that's available. I relate it back to other parts of our lives, and I'll give an analogy that is close to my heart related to shoes. I have many options when I want to buy shoes, especially for a pair of heels. I can go to Target, I can order off Amazon, but I personally choose to go to Nordstrom. And I have a bias towards them for many reasons, but I also know I'm paying a premium. I'm paying $200 for a pair of shoes at Nordstrom, which I could get something looks very similar, probably very functional at Target for about $35. But because I'm paying that $200, there's a reason for it and why I'm expecting more. As soon as I know I walk into Nordstrom, I'm going to get greeted at the door. I'm going to have a singular point of contact throughout the entire experience. They're going to give me a personal shopper that's going to let me try on one pair of shoes or 100 pair of shoes without ever complaining about it. And I know I will have an unlimited return policy. And I know that from experience. When I was pregnant with my first daughter, my feet grew a size. I went from size 7 to 7.5, and it never went back. I was at Nordstrom shopping for a pair of shoes one day, and I just casually mentioned, the sales rep was asking me what I was looking for because I was buying 5 pairs of shoes at once. And I said, I'm looking for new work shoes because my foot grew a size. And he said, bring them all back and I'll upgrade you with a new size, no question asked, no additional cost associated with it. And so because of my past experience, I know what to expect and I'm willing to pay that extra, but because I'm also paying that extra, I expect that kind of service. I'm not going to expect that same service at Target. And so I think that's the kind of the model that we're moving to in healthcare, because if I'm going to pay $5,000 out of pocket for something that I got for $500 a few years ago, my expectation of that delivery model also changes.
Yeah, definitely. I was just thinking of the Target. I have to oftentimes, if I'm going to Target, it's like you got to try on the shoe, and then you got to like see if you can get the rewards, if there's any value in it, and then it's like you have to do all the work, and sometimes the shoe is not great quality. But yeah, totally understand. As we focus on the patient consumerism, like you mentioned, I mean, it's not common in healthcare, and it doesn't typically work around consumerism for patient in healthcare. And honestly, in the past, I mean, we've always had this focus around ensuring that the patient had the best patient care from a clinical perspective, but how do you incorporate consumerism, like other industries do, like Nordstrom's, and create the happy customer? Providers are being measured on patient experience, and typically surveys, they're not normally given to patients until after their discharge. So, that patient will receive great care, and they could forget about it once they get the bill. So patient experience it's key now, and providers are measured on that. With HCAP scores in this study, it was focused on the patient's overall experience, and it was determined that providers with higher scores had better financial outcomes. 46 to 56% of patients are dissatisfied with the amount of cost that's information that was available to them on the front end prior to having their service. And patients are shopping now, so they have access to improved ways of communication. And so it's really important to provide information accurately, have consistent communication, help that patient through the, through the process and catering to their needs. And so we're going to talk about that a little bit here in some future slides around advanced segmentation. So if we go to the next slide, just talking through and thinking about that example that you gave, Lakshmi, we find that there's this symbiotic relationship between patient responsibility and service level expectations. Now, as we see the patient responsibility rise, the cost burden is shifting to the patient, and we're seeing that there's also this increase in the service level expectation. So patients know they're responsible for paying for their care. They want the better experience for their money. They want better quality of actual administrative services for their money. They want, high level patient responsibility equates to the high level of service expectations. So the more we expect patients to pay us, the better we need to be in providing some of those administrative services to patients. So we're going to go through the patient is in, the center of the revenue cycle. So we're moving through that concept, patient's the payer. We talked about that, right? Really, when we put them in the center and we look at their ability to pay as a key component to enhancing their experience, there's a couple of things that are important. One is the access and coverage determination. So helping patients understand their coverage as it's applied to their account. Estimation of liability and propensity to pay. So really helping the patient to understand, as well as the staff communicating with the patient, what their liability is. So it really helps here is the education, right? Not only provided on the front end, but to anyone that's working with that patient. So hospitals, health systems, vendors, physician offices, they're all aligned on these topics, right? And it's discussed with the patient in regards to their liability. And a lot of times patients do defer care because of liability issues. So it's important for everyone to be involved regarding and understanding that approach. Enrollment qualification. So patients that are presented as uninsured or underinsured and having the ability and knowledge on what programs are applicable for them, that helps with cost. Point of service account resolution. So this is a barrier to health systems, especially with liability. And it's important to have conversations in that beginning of the process rather than the back end when they get the bill, right? Post-service account resolution. This can be for services that you're unable to obtain the estimate at times. Right? So the patient comes in and maybe there's a different procedure that was, chosen by the patient, chosen for the patient by that physician. So being able to interact with, systems using patient segmentation, it can really help with working with patients through these type of situations. These are all options too. I want to mention this, when we talk about virtualization, right? Use of technology. A lot of these things can be done in a virtual, remote environment with having the technology to support it. So paying by phone, using portals online, you can even use mail if you have to. But there's a lot of these functions that can be done in that remote environment. So we're going to go into patient segmentation. So reducing the cost by investing in advanced segmentation. So overall costs can be reduced, right, by investing in advanced segmentation, and these items can be done remotely and virtually as well. So you can reduce employee turnover by ensuring that, with HR education solutions, that you hire the right people who engage with patients and they educate patients, right? It requires a new caliber of employee that provides quality and establishes the relationship with the patient. It's no longer the check move, right? You really need to build relationship with your patients. Patient access team, they're really the gateway to that revenue cycle, and there's a lot of turnover in that area typically. So having colleagues understand, their importance in the patient access through education and understanding the why and how it impacts the rest of revenue cycle is super important, and having the tools to effectively, perform tasks and meet the overall goal. Reducing financial risk by addressing liabilities before they become too intense to collect, right? Or resource intense to collect. It's important to have the ability to collect through scheduling, registration, point of service while that patient's in front of you. You can even perform the collections through eligibility enrollment services. Deferring low-touch patients through automatic and digital channels. So, we're in a day and age where technology is key, right? Especially targeting population that prefers to use technology to handle the bill. And then utilizing high cost resources. So, typically we see the decentralized models where, patients are going to multiple departments, to either schedule their appointments, liabilities are estimated as they go along. So just having algorithms that really give a sense of more of the complex visits, saving costs by identifying the number of calls that go to the patient based on their situation really helps with productivity. So we go to the next slide, we're gonna really look at the new way of thinking with access strategy. So looking at segmenting patients into quadrants here, right? So you have your high touch, low touch. Really, this is the patient engagement as a consumer. And then you have your high risk, low risk. And this is the risk to achieve payment as a provider. So we have 4 different quadrants that we're going to just go into detail here and talk through. So we look at quadrant 1 on the high touch, low risk. And if we can go to the next slide. Really, high touch, low risk, these are typically the insured patients that have the high financial risk if the patient's not guided and worked with constantly, right? So they're low risk financially, meaning they have complex, more comprehensive benefit plans. And it's low risk from the organization because, majority of the dollars are coming from the third party payer. But the patient has oftentimes a complex care plan. And so there's this complexity there in the amount of visits that they're going to have, in being able, the complexity around the services and the type of providers they're going to have to see. They could have a complex or incomplete benefit plan. But it's really important to be an advocate to support the patient in understanding how their benefits are being applied, and really education engagement with that patient.
We do have a question about this slide, asking if you could please provide an example of high touch, low risk patient, a specific example.
Yeah, perfect. So I think some high touch, low risk patients, I think about, we have your recurring enrollment, right? So patients that may already be on Medicaid, they may already be on a payer with Medicaid, but being able to ensure that you're maintaining that patient's benefit after the program enrollment long term. So being able to continuously work with that patient, ensuring that their income doesn't change, month to month, making sure their spend down is done appropriately. I think of your long-term care settings, your patients that are receiving home-based waiver services, your intermediate care facility settings, essentially just being able to ensure that you're guiding that patient. So financially, it's a low risk because they're already on a payer. But, when it comes to the touches, there is some high touch involved because that patient could easily fall off because Medicaid determines income on a month-to-month basis. Another one that I think about is, we look at obtaining secondary Medicaid for a patient, right? They have a primary payer, but you want to be able to give that patient the overall satisfaction financially, and being able to help with getting them on a secondary Medicaid. So it does require a lot of high touch, but from a financial risk, it's low, if that makes sense. All right, so we're going to talk about the next quadrant. And this is really the meat and potatoes of eligibility and enrollment services. So we talk about high touch, high risk, right? This is your quadrant 2. This is your uninsured, underinsured population. So these are typically when you have financial counselors, you may have eligibility enrollment team or vendor in place, and expanding the review for all payers to cover the data service. This is about creating the high touch experience, as it's both the patient and provider's best interest to guide the patient through the process for resolution, right? So it's important to have a delivery model of people, technology, and processes. When you're looking at people, you really want to look at, do you need to have on-site staff versus remote staff? There's a lot of initiatives when we think about virtual technology with, telescreening, video conferencing, which creates the same exact engagement remotely with patients as it would in person. You can use electronic screening tools, your proprietary workflows, your outreach through different modalities. So you're emailing, you're texting, your dialer contact, your letters, pursuing your eligibility verification, all ways that can be done remotely and create the same outcome. When you think of other technology that can support your uninsured, underinsured population, you can look at propensity to pay. Identifying not only just their credit score, but the advanced function of propensity to pay with, identifying their debt to income ratio, their household income, their household size, and being able to segment and identify what requires the high touch, right, versus a low touch. Utilizing charity tools, presumptive charity tools, having, HL7 feeds versus, waiting for files to be placed, after a certain time frame through batch filing processes. Robotics and automation, so being able to have screen scraping real time versus the administrative, someone manually going in and checking benefits off, right? Workflow can be automated. When you think about like Epic, right? You can actually, if you have a proprietary system, you can automate workflow without having to have someone actually go in and do it. You can utilize, your being able to automate billing indicators and moving them through the process. So just being able to have standardized best practice, sufficient workflow, and the right metrics really helps in this area. So I want to do a poll. So I'd like to understand, which of the following, if any, do you perceive as the top challenge with leveraging virtual technology for patient engagement? So you think about telehealth, telescreening. All right. All right. So we got the results in here, and it looks like 29% have a lack of technology access. Got it. 58% is the lack of digital literacy in the patient. 13% is low patient engagement. Oh, did someone have questions? Sorry. Okay, awesome. So Yeah, so I think this is, these are great numbers. And we're kind of seeing the same as well. So I want to go into the next slide. I actually kind of want to talk about telescreening. Especially as it relates to these stats. The healthcare landscape has continued to evolve, right? So even more so due to the pandemic, patient access is becoming virtual, right? When once the pandemic is regulated, patients will continue to expect the simplicity and the security of virtual visits, and the demand will continue to rise. Healthcare organizations, they need to continue to incorporate secure telehealth technology into their business operations to increase their patients' access to care while decreasing the overall healthcare cost. With recent initiative of implementing telehealth delivery model with providers and the increased acceptance of this, we can use that same thinking, that same modality to enhance eligibility enrollment services with the concept of virtual screenings. So I want to go into the next slide and talk about virtual screening. So very much like I'm on the video right now, patient would be on the video as well, talking to a patient virtually, right? So we think about value drivers for virtual health. Why is it important? Really, essentially, the patient professional safety following social distancing guidelines, right? That's number one. Traditionally, we see that high turnover with patient access. So having a team that works remotely in that centralized fashion, it supports turnover as needed. Some benefits, you're increasing cash. You're reducing overall self-pay recurring rates for your area and your facilities. You're reducing the uncompensated care and bad debt, protecting and enhancing the patient experience. So types of environments that you can actually use virtual screenings or video conferencing with and get the same outcome is really, patients when you're doing pre-registration, your financial clearance center, right? You can look at your unplanned emergency areas, emergency room, your outpatient services, your clinic settings. These all are areas that can be used for virtual conferencing and being able to connect with patients. So when we go into those contributors, like, well, how do I set that up, right? How does that even work? How does that create, how can I get this to be successful? Essentially, you want people, process, technology, right? So with people, you got to ensure you have the right staff with the volume analysis and the right caliber of staff that can support coverage outside of your normal business hours, right? Similar to a call center environments where you have like a pooled team. Colleagues have camera capabilities, appropriate backgrounds, right, for your organization in their environment. They can access programs to support patient program through screening tools. They can help apply them and enroll them while they're on their desktop with, the appropriate payer portal areas, right, to access, or Medicaid portals to access. They can identify quickly, is this a patient that's going to be good to connect with virtually using face-to-face technology? Or do I have to use other modalities for contact? Do I need to maybe call them on the phone or use text messaging or do an email? Or do I need to send a field visit or a courier? Do I have to actually be in person? So we can identify that, right? To be able to ensure that we're working with the patient on what they prefer and what they need. And we're delivering the appropriate contact, and we're working through their mobile devices, like such as their phone or their iPads or even, tablets, and just being able to have that access to them. Technology, so identifying the program that works best for face-to-face screenings. You want to have something that's BAA compliant, that has recording and waiting room capabilities, that establishes work queues, for connecting with patients when you're segmenting patients virtually. Easy appointment scheduling if the patient's not able to connect. And just being able to ensure that you're testing the Wi-Fi in those areas where you're going to implement a virtual work stream. When you think about process with workflow, you want something that's really easy to follow, give step-by-step instructions and guidance to colleagues to perform in this role, right? Compliance is a big one, right? So it's really important about having the appropriate disclaimers signed and acknowledged, sent to the patient prior to connecting with them on their mobile device, ensuring that there's, you're honoring digital communication with patients and ensuring that the patient can opt out of text messaging at any time or stop the face-to-face meeting and connect through different modalities of contact. Also ensuring that you have electronic signature capabilities is really important for not only your state, the state that you're participating in with those programs, but as well as other forms that you need to have signed.
And we do have a question.
Yeah,
Sorry to interrupt you,
absolutely.
Amy. What are some ways to help patients who lack access to technology or struggle with digital literacy?
Yeah, it's a great question. Definitely, I would say that being able to offer or provide like an iPad or tablet in your service area. Like we actually partnered with a client where they have their own iPad. It's encrypted, really can't be, they have it secure. They have a process for checking it in and out. If a patient walked off with it, it would stop. They wouldn't even be able to access any programs or anything. But it was in a way for us to connect, virtually with the patient. Also, instructional handouts are good as well. So being able to show like, this is how you download Zoom, right? These are the steps you take on your mobile device. And also completing disclaimers. Maybe they're not able to function through the disclaimers on their tablet with the program or sign electronically. So having those disclaimers maybe through the registration process or the packet where they can actually sign it there physically with the registration rep. So those are all different ways. And then obviously, if you're unable to connect with that patient virtually, it's always important to offer the different modalities for contact. So being able to say, hey, I'm going to just pick up the phone and call you, right? Or pursuing, mail or field visits. It's actually, I wanted to kind of mention this, and I don't know who else like watches TikTok on their downtime, but I do. Okay, I do. But essentially, there's a TikTok revenue cycle. There really is. I promise you. And I was actually watching this physician talk on there, and the physician was talking about how they were pursuing telehealth with her patients, and she wasn't able, like the patient really didn't have the digital literacy to connect. And so they actually hired a paramedic company that goes out to the patient's home to do guided examinations while that doctor is seeing them through virtual capability. I just thought that was really cool. It's really neat, like all the different ways people are thinking of to connect with patients.
Hey, Amy, I think one other thing to add here, and on the slide, you guys will see process, people, and technology, and there's thought and reason behind that order, because whether it is the lack of access to technology or the literacy behind it, it's the process and the people that help accompany what technology you're going to use and how you're going to use it. And so the things that Amy, you were mentioning in reference to other options or kind of that streamlined approach. So you're gathering that information and understanding, hey, Steve doesn't know how to use his iPhone, or Lakshmi is going to struggle because it seems like she may be in an area that doesn't have great Wi-Fi service. And so in that earlier stages of the relation conversation, you are understanding the needs that I'm going to have as a patient or Steve. The other piece is when you think about technology, and it's not a big lift in this area. We're not talking about a Epic install or a pass install. In basic things like Zoom, FaceTime, and so forth. So with CMS kind of getting a little more lenient on related to technology restrictions for both patients and provider has opened up a lot of opportunity, not just from a telehealth perspective, but the use of telex, so that virtualization of a different component. And so in a world where we can use Zoom now, where we probably weren't able to use it a couple of years ago. And so they're small incremental changes that can make a big difference here.
Yeah, absolutely. And then like if we go to the next slide, this talks about the types of coverage and programs. So we talked about connecting the patient to the right program that supports the provider for reimbursement and getting the patient on the right program. So, I mean, there's over 20 plus programs that patients can qualify for that help them to obtain coverage, community benefits and support, preventative care, monetary benefits, reducing liability and out-of-pocket expense. And then the next slide on this high touch, high risk is really around eligibility enrollment process overview. So taking that workflow with service delivery and technology enablement that allows a lot of these services to be performed in a remote environment. Using a dialer system, a technology that can at least, record your calls, video conferencing, electronic screening tools, text messaging, emailing. Those are some of the ways that you can support the patient connection from a remote virtual standpoint and get the same results. There's a need to flex those options for connecting with patients.
We do have a question, and thank you to our audience for your questions. Keep asking in the chat pane. The question is, where have you seen the most success in this process utilizing virtualization?
Oh, that's a great question. In terms of adoption, of the work streams that you're seeing here with screening, application, approval, billing, and the billing follow-up, we found that application follow-up was the most successful working remotely in the virtual environment because even prior to COVID, you have electronic signature offerings, especially with, ACA, the impact with ACA. You have partnering with your state offices to obtain resolution of applications in a virtual, as long as you're signed on as an authorized representative. Following behind that trend now is the screening work stream, and there's collaboration with key patient access departments regarding processes that help with the handoff for the right folks to connect with the patient virtually and take those applications. Where we've seen the most success with process and communication has been rural and community areas where there's been a lot of lack of resources and availability. All right. So moving on to measuring performance. So really important to measure, you have to have key measurements to measure performance, right? And so here are some of the ways that you can measure performance. Screening rates, application rates, aging statistics, your call center metrics, quality audit percentages with your team, and then you have your gross and net conversion rates.
Hey, Amy, I love data and I love metrics and KPIs, but I know as organizations get inundated with data, if you had to recommend 3 metrics for measurements to really evaluate the success of the program, which one should they prioritize?
Yeah, it's a great question. I would say the top 3 would be gross conversion rate, right? Number 1, gross conversion rate. There's actually benchmarks for gross conversion rate with HFMA. They break out their rates by inpatient, outpatient. You also have NAHAM access keys, but typically those conversions are also accounting for like financial assistance as well. From a Civista perspective, we actually get a little granular. We take our conversion rates by breaking them out by patient type. So you got your inpatient, your outpatient, which is like your ER, observation, outpatient. We're taking, and that's your approved. So of what you see as a uninsured referral, right? How many did you approve? Like that's your gross conversion. And we actually break that out by expanded and non-expanded states. So what does that mean? Expanded states are states that offer Medicaid to childless adults. There's 38 states that have adopted expansion. And then you also have non-expanded states, and those are your traditional Medicaid enrollment for age blind, disabled, pregnant women, children, or parents or caretakers of children. And those are 12 states that currently remain as non-expanded. I would say number 2 would be screening rates. Definitely your screening rates, making sure that you're measuring how many patients you're actually getting to and connecting with, because maybe you need to flex in how you're trying to contact. Some states don't respond well for certain things like dialer, right? Versus text messaging, where other states do. And then looking at your application rates, definitely your application rates and how many of those screenings you're actually submitting.
Great. Thanks, Amy.
Yeah. So just when we go into quadrant 3 here with the low touch, low risk, I mean, these are patients that don't want a lot of interaction, right? They want to pay their bill. They need a simple and easy way to do so. This is one of the areas where, this is patients most like this audience, right? They know healthcare, they want little interaction, they prefer electronic communications, and they want accurate estimates. These are patients with simplified care plans and comprehensive benefits plans. The connected patient is a consumer who demands to be at the center of services. 72% of U.S. consumers are most likely to choose the healthcare provider that offer service channel flexibility. 80% of consumers have had virtual care visit and will have another, right? So if we go to the next slide and we're just looking at the different types to be able to connect to the connected patient. Essentially, you have self-service portals, scheduling, self-registration, having alternative methods for payment, so credit card, Apple Pay, being able to take card information, and uploading that. And then having online pay. So just having all of the different types of communication available for that connected patient. And then we go into the last quadrant, which is essentially your low touch, high risk. And these are those patients that do not have all the they don't have all the complexities from the financial perspective, but they're most likely unable to pay or unlikely to pay. And so this is really where point of service collections comes in. We do spend a lot of resources trying to collect from every patient. So the goal here would be able to identify this population that's underinsured and doesn't qualify for financial assistance programs and has a history of non-payment post-service. So that approach is a little bit different. Really important to have good point of service best practices. This is where it's important to have your charity care or presumptive charity care review in play. Having a good screening tool that can help support and identify, how to handle that patient, propensity to pay. So just, taking information and understanding how they've paid in the past from a healthcare perspective, and based on that financial information, you can predict the ability to handle their financial obligation. So I wanted to kind of talk through, I talked through all those quadrants, and I wanted to get your take on, additional ways that we can support, and so I wanted to, maybe if we can start with a polling question first.
Yeah.
So with the polling question, we have here, what is your biggest hurdle when it comes to patient balance? So patient balance.
Yeah, so I just want for clarification, when we're talking about patient balance, we're talking about all patient responsibility from an organization standpoint. I wonder how much all of the above we're going to get.
Yeah. It says I can't vote. I mean, I would choose all of the above. Just saying.
Yeah, see, all of the above. We call that being a very managing patient responsibility and patient balance. It's a hard job, and Amy, you mentioned this earlier on the presentation. I mean, patient responsibility is the third largest payer. I mean, I know it goes from second to third depending on the year or the last few years, and so managing that AR it's a big challenge. And how do you work through that? And I wanted to spend some time and tie on in the last few minutes we have together, kind of tie in our overall presentation together, because we've talked about telehealth, we've talked about virtualization, we've talked about consumerism, and then kind of eligibility enrollment. And the reason of that is the shift in movement and the momentum we've gained as an industry to really create a holistic view of a patient and kind of meet patients where they're at. So based on a recent consumer impact study, and it ties to the other data we presented overall, but 40% of patients said that their interaction with the hospital billing influenced whether they would recommend a hospital to a friend. And a patient who's had a negative billing experience are 5 times more likely to complain about the experience to another patient. So customer service and consumerism and the consumer experience matters greatly right now. And in other industries, as I mentioned, like Nordstrom as an example, but in other areas, I mean, I've given this example. I had to buy a washer and dryer recently, and within minutes of a good Google search, I was able to find out the best options of what, size, scale, what met my family's need. I could figure out which one, how to get it delivered to my house, what the repair situation would be, all of those components within seconds. That's not really possible within the healthcare space right now. Maria, if you'll go to the next slide, I want to kind of demonstrate our current situation we're at. So when we look at current processes from patient access to all the way to bad debt, whether you offer these services or an organization offers them in-house or has a vendor, in many cases, we have siloed processes and siloed organizations. So you have, patient access, point of service, registration, you may have an eligibility service, you have financial clearance, then you have self-pay, whether you do it in-house or a vendor, and then you separate bad debt. And in these components, you have a different phone number, a different letter, a different mode of contact, a different way of communication. So the patient is not getting a holistic experience that's consistent with the kind of the model that they expect in other areas there. So this also provides kind of the lack of information here, and how do I know what I'm going to pay, what service I'm going to get, what my aftercare is going to be. And those are the things that we find out after the fact. It's not a lot of education on the forefront. I know price transparency tried to change some of that with information that is available from a cost perspective. And that's only available when there's patient-facing estimators on our websites, but publishing a CDM doesn't really give a non-educated person on revenue cycle what to do with that information. It doesn't matter what the charges are, it's about what I'm going to pay on it. So if you go to the next slide, from an approach standpoint, how we want to tie all of this together is what we call a patient balance management program. So it's a consolidated team with visibility into the full patient balance journey. So it's to simplify the billing process, simplify the experience there, and it integrates financial clearance, eligibility, patient advocacy to the back-end collection efforts of self-pay and bad debt. And it's all supported through a virtualization call center. So it's a consolidated team with the visibility of the full journey. It's ultimately there to kind of create a consumer-centric healthcare experience to increase the overall satisfaction and ideally yield higher financial return.
So Lakshmi, I was just curious, how do you avoid compliance mishaps by integrating that viewpoint of patient balance management?
Yeah, no, good question. And typically when you talk about compliance, it's more about the integration of self-pay and bad debt. So federal and state regulations related to debt collection has to stay, and it's in the forefront. This is more about the view of an experience of the patient. So a patient calling into a call center to ask about their balance has to acknowledge and inquire that they have a self-pay and bad debt balance before we can talk about it and actually essentially close the bad debt balance, move it to self-pay and have that conversation. But it's making sure that the same vision of the organization is felt throughout the experience. So modes of communication, the views of education. So it's bringing the patient into the conversation versus it being a reactive conversation. And Steve, I think we're at top of the hour, and I don't know if we even have
we're at the
time
top
for
of the
a
hour.
question. Yeah.
And we've had questions throughout. The one question we did have, will the slide deck be shared? And we will make sure all attendees get that, as well as the recording within 48 hours. But that takes us to the end of our webinar. Thank you again to our speakers for this excellent discussion about such an important, relevant topic right now. It was such a pleasure to talk to you both, Amy and Lakshmi, today, and hear about your shoes and your washer and dryer. But those are really good case study examples. Their contact information is on screen. And to our audience, thank you so much. We value your feedback. Please take a moment to fill out our brief post-webinar survey so that we can provide the best content and resources for you in the future. We'd like to once again thank the sponsor of today's webinar, Savista. For more information, please visit savistarcm.com. Savista Revenue Cycle Management.com. This webinar will be available on demand, and a link to a recording will be sent to attendees within the next 48 hours, like I mentioned. And this concludes today's presentation. Thank you for attending, and have a great rest of your day.
Thanks, everyone.
Thanks.